Good afternoon. We are the only thing separating you from dinner. So we'll do our best over the next 90 minutes to both educate and entertain so that your appetites are good for dinner. So my name is Marty Leon. I'm the anchor person. The spokesperson is my great friend Alexander Abizad. Discussants are the inimitable Antonio Colombo, Samir Dani, and Azim Latib, and we have many speakers and a very packed agenda. So we'll do our best to keep on time, but we do want to make this interactive in a way that you have an opportunity to ask questions, because we think when we talk about what are the hottest areas in coronary PCI, I must say that drug-coated balloons now have become one of the hottest areas. It's being discussed everywhere now in the United States. So I think it's become very topical for us, and the session objectives this afternoon are first to educate you, although many of you are probably familiar, on best clinical practices in terms of how to use drug-coated balloons, and specifically in this case, Sirolimus-coated balloons from the standpoint of technique, to understand about the specific technology that we're referring to, at least in this symposium, sponsored by Concept Medical, which is the magic touch. And you'll get some interesting data that familiarizes you with some of the nuances and differences of the technology, and then to drift from what are the current clinical indications and use patterns to what is possible with drug-coated balloons. And in this case, we'll show you some clinical experiences, we'll talk to you about some of the clinical trials that are being done, and we'll give you a sense as to where drug-coated balloons can be in years to come based upon some of the clinical evidence that's being generated. So I'm very excited that we're going to have an interesting discussion. We invite comments from the audience, so we will allow some discussion time between each of the comments. We have the opportunity to take some questions from the chat, but also there are microphones that may be easier for some of you to ask some questions as well. So I'm going to begin by introducing the first speaker, who is a great friend, probably among the world's experts now in this specific area of preclinical assessment of new intracoronary technologies. And that is Alok Finn, who'll talk about Sirolimus-coated balloons with nanolute technology, evidence from the preclinical data. Alok?
Marty, thank you so much, and congratulations to you, especially to Alex, recently on his promotion. It's a big deal. Like to say that. So Marty mentioned, my area of specialty is I'm a clinician, but I also do a lot of work on preclinical data and do a lot of work with drug-coated balloons. As you all know, that drug-coated balloons mainly at this point consist of paclitaxel-coated balloons that elute paclitaxel in different doses, different excipients, but there are just a few Sirolimus-coated balloons which are emerging as promising players in this field, and the Magic Touch solution, the Magic Touch balloon is one of those new technologies, and I will dive deeply into this technology in this talk. A lot of clinicians simply think preclinical studies are not that important. We want to see the clinical data. But I think as a clinician, you need to understand the basics of any technology. And you can understand at the preclinical level, at the histologic level, preclinical studies provide that level of resolution for how a technology works. And they're obviously required by the FDA before human use and often reveal responses to DCBs and using techniques and methods that we cannot obtain from human clinical studies. In the end, every device has to be evaluated for its efficacy and safety, both in clinical studies and preclinical studies. But safety is the major function of preclinical work. And the DCB, as you all know, should have its local arterial effect, but it also sheds particulates. Every DCB, to some extent, sheds particulates. So it's important to understand how to evaluate those particulates and what they consist of. And we need to evaluate non-target organs, not only the treated vessel, but the downstream organs as well. And I'll show you some data for that. Paclitaxel is well known for DCBs. It's been around for a long time. Early work by Granada, et cetera, showed that the crystalline form of paclitaxel is the best because it simply retains over time in the tissue wall, leading to better prevention of restenosis than amorphous paclitaxel. I'm not going to review more of that, but you know that crystals crack and they flake and they break off. And the problem is that crystalline paclitaxel has a fair amount of that effect in the arterial wall. And we've shown this in older studies now with the DCBs that were approved for SFA interventions many years ago now. No matter which DCB, paclitaxel DCB you choose, Impact, StellarX, Ranger, we showed all of them to some extent shed emboli, and those are detectable in downstream tissue beds. Now, why does this matter? You say, oh, clinically it doesn't make a difference to me. Well, you know that paclitaxel, it can lodge in downstream tissue beds and arterioles, causing slow flow and ischemia or infarction. And so we want to make a technology as good as possible without any unwanted side effects. And especially for BTK, where DCBs have never worked, you know, slower flow after intervention associated with decreased wound healing and a greater rate of amputations. And we know that because DCBs have never been approved for BTK indications. So this is one area that release of paclitaxel may make a big difference. The Magic Touch balloon is a different type of balloon. Of course, it does not paclitaxel, it's sirolimus. It's encoded in these submicron particles, these phospholipid particles, and they're coated right onto the balloon. And these are small particles, surface area is 6 centimeters squared. It's very small and tiny particles, a totally different matter than the paclitaxel products. These submicron particles are encased in a phospholipid carrier and spray coated onto the balloon. And, you know, we've done a lot of work with Magic Touch at CVPath, huge amounts of work. And that has led to multiple IDE approvals. I think this kind of approval is a testament to the safety of the product in terms of all of the different approvals they've got in the United States. Now, safety, I'm just going to show you a little bit about the safety because I talked about it a lot. Preclinical studies. I'm not going to show you all the GLP studies. This was just a head-to-head study we did. Magic Touch, Solution, which is another sirolimus-coated balloon, Agent, which, as you know, was just approved in the United States for ISR, and POBA. And we use these in porcine coronary arteries because this is where the FDA really focuses on. Porcine model, coronaries, or peripheral. It likes to see data from that model. And you can see here in this particular study, we randomized animals' arteries to Magic Touch Solution or paclitaxel agent. Follow-up angiography was performed at 28 days and sacrificed and histology. I'm not going to show you all the data, but I'm going to tell you that we look at downstream tissue beds by sampling the downstream myocardium from each artery, which areas correspond with which territories of myocardium. So we can tell the downstream tissue beds in this area. And you can see there, when you look at the differences in terms of histologic effects in the downstream tissue beds between these different balloons, you can see that there's a distinctive effect of the paclitaxel-coated balloon agent in terms of myocyte necrosis and scarring. It was the only balloon associated with downstream myocyte necrosis and scarring versus the other three, the POBA, the Magic Touch, as well as the Solution. And you can see emboli really corresponded nicely with that. The greatest for paclitaxel, next for Solution, less for Magic Touch, and the least for POBA, as you'd expect. It's really not coated with anything. And you can see here's an example of the tiny little areas of particulates that go downstream, and these are easily detectable by histology. You can see surrounding areas of inflammation, eosinophils, and especially for the paclitaxel-coated balloon, areas of fibrosis and scarring that occurred after the balloon was deployed. And you can see in coronary arteries, the tissue levels of Magic Touch and Solution were not quite as high as a paclitaxel-coated balloon, but the downstream myocardium was also less full of drug than with the paclitaxel-coated balloon. So we had a lot of emboli with that balloon. And this is just a study that was performed in the rabbit model, which showed the opposite results. I just want to address this for a minute. This is really not an approved model to look at this. And every study we've done with paclitaxel-coated balloons has showed emboli. This study did not show any with agents. So it's hard to really justify that, I must say. And this is a paper I just published in JACC Basic Science, which showed, again, with a different paclitaxel-coated balloon, this one made by Medtronic. Again, the same thing was found. Scarring, it was essentially only found in the paclitaxel-coated balloon and more emboli in the paclitaxel-coated balloon. So in conclusion, I think generally paclitaxel DCBs are composed of crystalline paclitaxel, which is efficacious. I'm not here to deny it doesn't work, but it's associated with poor efficiency of delivery to target tissues and loss of paclitaxel into non-target tissues. And you see that again in the coronary model in multiple studies that I've shown you. And you might not detect this clinically, but it doesn't mean it's not occurring. So Magic Touch demonstrated less medial injury as well as downstream effect. myocyte necrosis scarring was absent in the sirolimus DCBs. It's important to note that as a class effect in this particular case, but present for paclitaxel DCBs. Emboli were much less frequent for the sirolimus DCBs. And these studies really support the safety of sirolimus as a DCB drug over current paclitaxel-coated DCBs, I would say. And the Magic Touch balloon should play an important role in coronary and peripheral applications going forward with the US IDE trials underway. So with that, thank you for your attention.
Any questions from the panel?
Let me have a quick question to
Yes.
Alok. Do you think that in future clinical trials, should we investigate these patients with multiple DCBs with, let's say, physiology, even if you don't want to put a wire there, all this less invasive QFR,
Yeah.
MIFR, et cetera? MIFR is great for microvasculature.
I think you're right, Alex. I think it's a very interesting idea. I think the microvasculature should be evaluated after these different devices to see how it's doing. Obviously, you know, in STEMI, microvascular perfusion is the most important predictor in some ways of recovery. So if the microvasculature gets compromised, that's a very important finding. I think, you know, periprocedural MI, things like that, could be monitored more closely. I don't know how closely they are being monitored in the studies that are being done currently.
Alok, there is a vast clinical experience with paclitaxel coating balloon in the coronaries. Why we cannot see any signal about these periprocedural MIs? There
Right.
seems to be a real entity.
Well, I mean, I think it's a real entity. The question is, how significant is it? You know, people have periprocedural MIs during PCIs, you know, Antonio, and they go home okay. So, you know, we don't really have a randomized trial really comparing, you know, we didn't get MRI. We don't have any way of getting very high resolution imaging done. You know, echo is not going to show you a big, you know, small periprocedural MI from paclitaxel. You've got to have very high resolution imaging. And I think the more balloons you use, I showed you data for a single balloon. Can you imagine if you used, these are, you know, limited balloons in the coronaries, but if you're using 40 millimeter, 60 millimeter, it's going to have a big effect.
Yeah, but I would have thought that biomarkers, just high sensitivity troponins, should have shown something if, you know, if there really was slow flow and, you know, and significant embolization.
Well, I think it's, Marty, it's hard to deny that doesn't occur. I mean, now,
Okay.
is it easily detectable? Are people looking for it? It depends on who's doing the procedure. If the proceduralist doesn't really understand the potential that can occur, they may not look for it. You have to understand the technologies to understand what can go wrong.
Yeah, one last question. You know, the issue of paclitaxel is safety. It's got a very narrow therapeutic window. So that's, you know, certainly favors sirolimus. The issue with sirolimus is, can you retain the drug in the vessel wall long enough to get equivalent efficacy? And you mentioned that, you know, it may be that the drug tissue levels are a little bit lower. What did you mean by that, and what data do you have?
Well, I think that I did show you, you know, there's data all over the place for PK, Marty. I think you hit the nail on the head. The PK data is very important. It's for efficacy. Preclinical models cannot predict efficacy. The PK really allows us to know whether the drug levels are high enough to predict long-term success. And I think for sirolimus-coated balloons, we need further improvements in technology to get even better PK levels. Paclitaxel has an advantage. It sticks to the tissue. It's got crystalline. It depots there. You don't want to have that for sirolimus. So I think your question is very well taken.
So I've used both in my practice quite extensively since, at least for the last 2.5 years, for the sirolimus, the solution. I mean, in the lab, I don't think there's any difference in no reflow phenomena for sure.
Yeah.
And we've used paclitaxel for more than, I would say, 10, 12, 15 years, and it works. It works well. I mean, if you're showing this fibrosis, it should translate into sudden cardiac death. Something should happen.
Well, I don't necessarily agree with that. I think no reflow is a very significant embolic event. This may not, you know, rise to that level. You know, you can get downstream emboli during a regular PCI and still get good flow. It's not like, you know, it becomes dramatic sometimes when you get a lot of burden downstream. But it doesn't mean it's not occurring, and it doesn't mean you shouldn't be aware of it. Now, if I were making a technology, if it was me on the table, you tell me I don't want a technology that embolizes downstream. I want a technology that treats the area and doesn't have embolic effect. I can only tell you what we show in the animal models. It's hard for me to believe this doesn't occur in the clinic. It's just hard to believe. How is it different in the human than it is in the animals? And every study we've performed with paclitaxel-coated balloons, peripheral, coronary, you see it.
Well, you know, I don't think these microemboli make a difference clinically,
Yeah,
because
we
if
just
that
have
had
to-
been
we
the
have
case,
so-
We have so much
rotoblators
to
would have been
cover.
gone out of the window a long time ago.
We have so many speakers. I'm sorry, but
One last question, just the role efficacy in instant restenosis. And what is the preparation you do before using the drug-coated balloon to treat instant
Well, I
restenosis?
think you got to get a good luminary, and I'll let the clinicians like
Yeah, we'll talk to
Antonio
you
talk
about
a
that.
little more about that.
we're going to ask Antonio to come up, and his lecture is going to be expanding the indications of use for sirolimus-coated balloons.
Thank you very much, Marty, and thank you for these opportunities. I have no comment to disclose. So when to use DCB to treat instant restenosis when predilatation results are optimal, I believe there is no controversy. In small vessel PCI, also here there are nice randomized trials supporting this. But then we go to some new indications, and that my talk is going to simplify the procedure. I really believe if there is one reason to use DCB is to simplify the procedure, and I will try to convince you. To avoid full metal jacket, especially on the left anterior descending, and in high bleeding risk patients to avoid excessive stenting with the need of prolonged dual antiplatelet therapy. To me, these are the three key indications for us to use DCB instead of stenting, which is a life-saving device. Don't forget that the stent are life-saving devices. So here is an example of how to simplify the procedure. Look, this diffuse disease of the circumflex. If you implant a stent, you can implant a long stent here. You will have not simple delivery, but can be delivered. You will have carina shift to the LAD with some problems. We pre-dilated with a 2.5 semi-compliant balloon, not a super result, but a reasonable result. And we deliver a DCB, and this is 1 year follow-up. Of course, anecdotal cases, but we have to wait large trials. But these anecdotal cases are getting more and more and becoming less anecdotal. Look at this ostial circumflex, another example. To simplify the procedure, pre-dilated with a high-pressure balloon and cutting balloon, post-DCB, no carina shift to the LAD, which is something that really makes the procedure quicker, less than 1 hour, and 1 year follow-up. So these are typical examples to support, to simplify the procedure. This patient with extensive disease, bifurcation of the left main, very calcific, we had to do rotablation on the LAD and on the circ, suboccluded OM, pre-dilated, 3 DCB, LAD, circ, and OM. This is a 7 months follow-up. There is some restenosis focal here because the result here is not pristine, and there is a focal restenosis here, but easy to be treated. But look at the bifurcation. We didn't do culotte, no decay crash, no stent, just rotablator and high-pressure balloon. To avoid long stents, second point, this long LAD, if this long LAD is treated in the United States of America where they don't have DCB, you implant long stents, or maybe you do medical therapy or surgery if you have an excellent surgeon. This was treated with a high-pressure balloon, non-compliant balloon, 3 long DCB, 6 months follow-up, DFR was 0.91. We can also say that we simplify the procedure. This is another long LED with diffuse disease, implanted a short DS 3.5, high pressure, and 2 long DCB, and here is a 1-year follow-up. Mauro Gito published a very important study to me in circ intervention with a long-term follow-up of drug-coated balloon versus matched long DS for the LED with some clear advantages for drug-coated balloon treatment. These are 147 patients, or more than anecdotal cases. And high bleeding risk, to finish. This is an 88-year-old gentleman with atrial fibrillation taking NOAC. This is a typical patient where you do not want to give prolonged dual antiplatelet therapy. And let me go back. This is the baseline disease, diffuse disease of the LAD, long lesion, was treated with rotablation, 3 DCB, the right coronary artery, cutting balloon, 3 DCB, we didn't implant a single stent. This is immediate result, no single stent, and this is a 6 months follow-up with evaluation of the LED of 091, and the right looks really nice. So these are 3 areas where I support use of drug-eluting balloon rather than the stenting. So I wrote last year this point of view in the European Journal, and I restate that DCB are as deliverable as DS. I would say most of them, maybe not all of them. DCB are as safe as DS. I believe now we can support this statement. DCB will close the left side branches than DS, especially for the LEDs, this statement is appropriate. DCD allow positive remodeling, except some types of DS. DCB preserve vasoreactivity. Most probably yes. We don't have strong data, but I believe we should. And the DCB do not always need a prolonged DAPT, and there are studies published, the debut study in Lancet supports such a statement. Thank you for your attention.
Yeah, we're going to have 2 more talks, so we don't have much time for discussion, but I'm really provoked to ask one question. When you do this kind of complex DCB work, long segments, calcified, angulated vessels, you're going to get dissections. I mean, you will get dissections. It's expected, in fact. Why don't you see more abrupt vessel closure with DCB, Antonio?
But, you know, 1 hour ago, they presented the data of the solution randomized study, and we see some bad dissection, and we have to cross over 15 to 20% to stenting. But many dissections are linear. The problem is that current community consider dissection a complication. I think dissection are graded, and this is a weak point of my presentation, that you need a little bit of learning curve to make some decisions and not jump to stent every type of linear tear, which many times is welcome. The first person to say that was Andreas Grunzig.
Okay, this is a perfect segue to our next speaker. You want to introduce our next speaker, Alex?
Yes. So Sandeep, where is Sandeep? Yes. Thank you so much, Sandeep. He's going to talk about how to perform a successful DCB angioplasty, tips and tricks, and he has a great experience from Great Britain.
So how to get good results and stay out of trouble. Is that right, Sandeep?
Yeah, I'll try. Thank you, Alex. I think I've been asked to kind of show how to perform a successful DCB angioplasty in 10 minutes. And especially after Dr. Colombo's talk, it's not going to be easy. I'll try my best. So this is my conflict of interest. Okay, so DCB angioplasty differs from a conventional angioplasty on several aspects. And this is what we're going to be learning in the next 10 minutes. So my talks will be focusing on patient and lesion selection, and more importantly, the procedural aspect, lesion preparation, followed by how to handle a DCB, how to size a DCB, and how to assess immediate post-DCB outcomes. So the patient lesion selection, as alluded by Dr. Colombo, the aim of DCB angioplasty is to minimize the stent length and to avoid stents when they are not needed. Okay, so for example, ISR is a classic indication where we want to avoid another layer of metal when a stent has already failed. And of course, these kind of lesions where you don't know which is a healthy landing zone, which will end up resulting in a full metal jacket, and we have burnt our fingers. So for example, this case, I treated in 2014 with great enthusiasm, converting the whole LID to a full metal jacket, and you see what happened. In 2017, it's closed. Of course, high bleeding risk patients who can't take DAPT for more than a month, or patients who are waiting for an urgent cancer surgery. And of course, side branches like these. And if you showed this to the bifurcation enthusiasts, they will say they'll do a DK crush or a culotte in both of those bifurcation. Would you do a DCB here? I personally wouldn't. I wouldn't recommend for someone who's starting DCB because there is no-go zone because there is no data. So procedural aspects. So what are we focusing here? So the lesion preparation. So we have to understand DCB is just a drug delivery balloon. So we have to pre-dilate the lesion. It's like painting a wall. So the painting is the DCB. Before that, you had to fill in the gaps and cracks and everything in the wall. Otherwise, you'll end up having a bad result like this. And we blame the technology, not the operator. So the decision to use DCB is made after the lesion preparation. You may think I want to use DCB, but you make that decision after the lesion preparation. So for the pre-dilatation, I normally start with a conventional balloon, semi-compliant or non-compliant, which will make me feel how is the lesion behaving. So I tend to use 1-to-1 balloon to artery ratio if I'm using fluoroscopy. But if I'm using an IVUS, I drop it by 0.2 to 0.3% because you're doing media to media. I tend to use a longer NC balloon, like 25 or 30, which is available. AccuForce or any of the Emerge from Boston, you get long NC balloons because it avoids multiple inflation. Second, I tend to inflate the balloon for at least 15 to 30 seconds. This causes some kind of ischemic preconditioning so that patient tolerate better when you inflate the balloon for 60 or 90 minutes, especially with a DCB. And also, it minimizes the recoil. So I'll show you this case. So this is a case of a mid-LAD stenosis. We pre-dilated. So we had not thought about DCB. But look at this. It's almost like a stent-like result. Okay. Now, when you see this, you don't need to do anything. You can use a DCB. So you don't need scoring balloon or a cutting balloon. So ready to paint the wall. Okay. When you need to up the game, when you need to consider scoring balloon, cutting balloon, or rotational atherectomy. So there are two scenarios. One, if the lesion is not yielding, or if there is a recoil despite a successful balloon expansion. So let's look at the first scenario, if the lesion is not yielding. So this is a case of done only last month in April this year. You see there's a very long stenosis in the codominant circumflex. So we took an NC balloon, inflated to 20 atmosphere. You could see the indentation there. So we did an IVUS. It showed an eccentric calcium, quite deep calcium. I took a scoring balloon. I don't know if it's a mistake or not. I could store a scoring balloon. I went up to 16 atmosphere. You could still see the indentation. And post-scoring balloon, the recoil is still there. Okay? So then I upped the game. I took a cutting balloon. And you see the cutting balloon expanded nicely. And I checked with an NC balloon again. Good expansion. I did the angiogram. You could see the pre-dilatation is much, much better. Okay? If you compare the two, okay, so that's a post-scoring balloon and that's a post-cutting balloon. You could see the clear difference in the angiographic appearance. This is another case, a mid-LAD calcified, dog boning, balloon ruptures at 20 atmosphere. Okay, did an IVUS, a concentric napkining of calcium with absolutely no damage from balloon inflation. So, IVL, okay, great cracks, you could see that. Okay, beautiful result, now it's ready to paint. So we can use DCB. So what is the next situation? So if there is a recoil despite a successful balloon expansion, so I'll show you this case. So this is a case done recently, flush occlusion of the ostium of the PDA. Okay, so we wire it, 3 mm NC balloon, post NC. Okay, there is TIMI3 flow, patient asymptomatic. Are you happy with the POBA result? If you want to stent, fine, because that recoil will be taken care by the stent, which will act as a scaffold. But if you want to use DCB, maybe not. Because there was a massive size mismatch, we decided to use DCB here. So I wanted to make the lesion progression better, so I used a scoring balloon. And you could see the post-scoring balloon, clearly things are better. And again, you can compare the two, post-NC and post-scoring balloon. And of course here, I tried to use the DCB. So we used a magic touch here. You could see The good thing about the DCB is you can come back into the main branch without having to worry, okay? And when I inflated the contrast, when I inflated the balloon and injected the contrast, you could see trickling into the PLV, which means it's not blocking of the main RCA. This is the case. So this is a mid-LED, okay? So we pre-dilated with a 2.5 and a 3 mm NC balloon, okay? And this is post-NC balloon, okay? Again, if you want to use a stent, perfect. You've done the preparation because its balloons are expanding. But obviously we were not happy. We wanted to use a DCB here, so we went to the scoring balloon. And you could see here, certainly the lesion looks much better now with the scoring balloon. So you could see here post-NC balloon and post-scoring balloon. There is no evidence to support routine use of scoring balloon or a cutting balloon prior to DCB if the lesions are well prepared. There is some data for a ISR, but not for de novo lesions. Post-POBA, you have to assess the situation. If the recoil is less than 30%, and if there is no flow-limiting dissection, you can go for DCB. So when you, of course, do the injection, you have to acquire till the contrast disappears, because you can see dye hanging up, which is a bad sign. Now you could see there is a small tear here. It's like, as mentioned by Dr. Colombo, a linear tear. It can be accepted because there's TB3 flow. This is another case. So it's a PDA, diffusely deceased. We pre-dilated. And this is post-pre-dilatation. You could see there's a linear dissection in the PDA. When I was using stent, I would be scared I would put a stent. But now I'm using DCB, I'm happy. So I left it. I used a DCB. And patient had a final result like this. Came back for a check angiogram at 6 months. You see the dissection is nicely healed, and the vessel is possibly remodeled. Mm-hmm. And you can compare that. Oh, sorry, I could have compared it, but anyway. But here, this is another case which was done in 2022. There's a diffuse disease in the circumflex system. I pre-dilated it. And then what happens? Patient develops chest pain. There's a spiraling dissection with TME1 or TME2 flow. So this you cannot accept. You have to treat this with stent, which is what we did. So this is called a flow-limiting dissection. So then when you want to take the DCB, you have to, again, go 1-to-1 vessel size for balloon to artery ratio. Don't touch the balloon as it triggers the drug release. Should be delivered within 2 minutes, and especially good for Magic Touch, it delivers very well. And it should not be reused if you cannot deliver it, okay, because the drug's gone. And normal inflation has to be 6 to 7 atmosphere for around 60 to 90 seconds. So here, for example, we have inflated the balloon for almost 80 seconds. You could see there is a ST elevation, but patient's tolerating very well. Post DCB, you have to check the angiogram, keep the wire in place, maybe do a second angiogram 2 to 3 minutes later, but avoid repeated injection of contrast because it will convert a non-flow limiting dissection to a flow limiting dissection. Post DCB, if there is no recoil or flow limiting dissections, no interventions needed and you can accept it. So bailout stenting is basically when you do a DCB and if there is either a recoil or a dissection, you have to treat with a stent. It's called bailout stenting. So here, this is a case done recently again. So there is a CT of the RCA. We crossed it, pre-dilated it, and looks okay. So there is some dissection recoil here, acceptable. So we used a 2 long DCB here, okay? Final result looked like this. Now, there was a recoil of more than 30% here after DCB use. Now, I would have normally left it because it's a CTO. I didn't want to kind of spend 2-3 hours opening an artery and to be closed later. So I put a very short stent. So I still got the benefit of DCB because the whole RCA was treated with a drug-coated balloon, but I only put a short stent. Finally, train your eyes not to expect stent-like result because we've all been trained in the stent era. So we expect stent-like result. So I'll show you this case. This again was done in March 2023 last year. Diffusely diseased LAD CTO. Okay, so it was opened up. We used a hybrid strategy, so Magic Touch in the mid and distal LAD, and we used a stent at the top end, and that's the final result. Okay, again, if you look at the stent and the DCB segment, it doesn't look very nice, but please accept it, resist the temptation to stent. And 1 year follow-up, so exactly 1 year follow-up, April 2024, last month, and you see there is an RCA CTO now, but the LAD is possibly remodeled. Now the last thing is intravascular imaging necessary or not. Not for all de novo lesions, but only in complex calcified lesions. Highly recommended for ISR. And again, this was a case I've shown many times. I think some of you have seen this ISR in the circumflex. I was showed a heavily undersized stent. And the distal reference was 4.5, and the proximal was 5 millimeter. So we used long balloons, big balloons, and we had corrected the mechanical issue pre and post. You could see that the stents have been fully expanded, and we used a DCB and a good result. Patient never came back. So if I didn't use the IVUS here, I would have probably not done justice for this patient. So follow-up angiogram is not necessary, but if you want to bring confidence, you can either consent the patient or go through a proper channel in your hospital. Sometimes the way I beat the system is I deliberately delay some of the stage procedure so I could assess the DCB result. So in conclusion, patient and lesion selection is important. Always pre-dilate the lesion, which is very important, more so in the DCB than the stents. Longer balloons and longer inflations recommended. Use specialized balloons if needed, don't hesitate. And type A and type B dissections can be left alone. Up to 30% recoil is acceptable. And avoid repeated injection post-DCB to avoid any further flow-limiting dissections. Thank you. And this was an article we published with Bernardo last year.
Sandeep, I have a question. How do you integrate the IVUS information in the DCB procedure compared to stenting procedure? Because I believe there are differences.
Yeah, I mean, I think the only time I use intravascular imaging is to prepare the lesion, to understand, like the lesion you saw, there was a lot of calcium. So then that will give me confidence to use a more scoring or a cutting or a balloon. But if I want to size the vessel, I tend to, as I said, drop it by at least 0.2 millimeter because you're doing media to media, unless you calculate the lumen size.
Yeah, I think it's very important. If you want to avoid bailout stenting, you should size according to angiography and not according to IVUS. Otherwise, you will have too many dissections and your crossover rate will be high.
That's a good point, yeah.
Yeah, these are great tips and tricks, and Sandeep, that was absolutely wonderful, but we're going to ask you some questions in just a moment. We have to finish this trio of lectures, so we're going to ask Luca Testa to come up and talk about how he tackles the complexity of really difficult lesions by combining DES and DCBs.
So thank you very much for this opportunity, and I have to say many of the topics that I am actually facing here have been already somehow introduced. So what is the point? The point is that, let me just start with a big statement. We are not against drug-eluting stent because, as Antonio said before, they are life-saving devices. And honestly, I have to say that when we talk about DCB, we need to remember that we are still in the phase of producing the evidence that will change our practice of putting stent all the cases. So in other words, nowadays the paradigm is PCI means drug-eluting stent. I don't agree. Point is, we need to demonstrate that we can have, let's say, a good option using DCBs. These are my conflict of interest. And I will start talking about this case. 71 years old male, some cardiovascular factors, and a very long-lasting cardiovascular history, starting a few years ago with a CABG, as you can see, Lima to LAD, and a vein sequential to first diagonal ramus, marginal, and RCA. And then multiple additional procedures. So this gentleman was coming back. He kept coming back. So actually the last time that he did an angioplasty was 2 years ago. But the point is that after 10 days from the last angioplasty, he had again relapsing angina. So this is the situation. So the vein to the PDA was patent, and there was no critical stenosis of the native PDA. So fine from that perspective. So what happened? So we're dealing with, again, this is ISR number 4 of that savannous vein graft. And it was going to a big intermediate branch supplying all the other 2 diagonals. So in other words, we basically discussed a lot about what was the good approach for this gentleman. However, if you look at this situation, you will see that the Lima is still okay, it's not a big deal. But then, that's the left main. So there is an ISR at the left main as well. So, I mean, just for you to remember, this was angiogram number 7 for this gentleman with ISR number 4. So in other words, we decide, okay, now it's time to do something for, let's say, the marginal, but tackling the native arteries. So this is what we've done. So we started preparing the left main, and at that time it was not really possible to cross with any imaging devices. So just a lot of ballooning, and as you can see, there is still some kind of tissue inside the left main, but obviously that was not our goal. Our goal was to reopen the marginal in order to, let's say, fix the problem of relapsing ISR of the vein graft. So we did. Multiple ineffective attempts, even using fine cross and escalating with the wires. So ultimately, we could not find the right way except going retrogradely. So I basically used the vein graft to tackle the lesion, the occlusion of the osteal MO, and then using, let's say, dedicated wires, I finally managed to reach, the possibility to close the circuit. I will just leave it there for you to understand what was the situation. But ultimately, the goal was to reach this situation. So, coming from the vein graft, I was able to go into the marginal and then to inflate a balloon to open the ostium of the marginal branch. Non-compliant balloon up to 2.5 by 15, and then a voluminous 3 by 16. So I'm not talking about a DCB in this case. So I intendedly decided to use a drug-eluting stent, especially there, where there was a lot of tissue, a lot of stent struts, but honestly, I have to say, that was not the end. Because as you can see now, there is a diffuse disease involved in the proximal and mid portion of the marginal, and then, at that time, I decided to do some imaging. I will let it run. I'm sorry about the quality, I don't know why, but anyway, there was just a huge, very long plaque ending up in the stent. It was actually fine. So, next step was to do this casing balloon in order to create more space and to reevaluate the possibility of, let's say, a better endothelium function, possibly gaining more lumen at the artery, but it didn't happen. So, I did the pot, and then I reevaluated. But at that time, the only chance to really optimize these results was to use a drug-coated balloon. So in other words, the idea was not to use either the DES or the DCB, but to integrate in this complex situation the possibility of having both where they were needed, especially in this relatively small vessel, where I honestly thought the possibility to use another stent was not a good idea. So I used DCB, and that was the final results, as you can see here. Okay? I have seen this gentleman a few months ago, and he's still doing very well. So, honestly, this is just an anecdotal case, but it's only to show you what we should be doing. And again, if you want a peace, you need to prepare for war. So in other words, nowadays, the concept of modern PCI is not just deciding up front if you want to do a DCB only or a DES only. You need to be prepared to use both. And then it requires a set of skills and equipments, of course, because we need to build up our own experience in using DCB. Because a DCB is not just a balloon, it's a way to deliver the drug. So the job has to be done before using the DCB. Victory favors care, because in complex PCI, there is a need for changing the strategy whenever one is not working. And who does not change is on only the highest stage or the most ignorant fool, which means that changing the paradigm of PCI means displacement into a selective use of drug-eluting stent or DCB, the so-called hybrid approach. I do believe that nowadays is paramount to optimize the results of modern PCI. Thank you very much.
Okay, so we had some complex PCI and we had some philosophy also. Yeah, very good. So we have a few minutes for questions. Does anybody have any questions before the panel gets going on questions?
Come up to the mic.
Come, please.
Use the mic.
There's a
Because-
microphone there.
Because you're getting a postgraduate course before we have our undergraduate degrees here.
Hello. How often do we have to do control angiograms, and if so, what is the ideal time to do it?
You mean the follow-up angiography?
Follow-up.
Right. Well,
Excellent question. And I would follow that with, after so many tens of thousands of DCBs, why don't we have more systematic post-DCB control angiography so that we can discuss with people what the angiographic restenosis rate is?
well, Good question, but also complicated questions, because from a clinical point of view, I should say there's no need from a clinical point of view. However, we are not talking about the clinical results, especially if you are dealing with small vessel, because we all know that all these patients will be on tablets as well. So they may actually, let's say, soften the angina events. In other words, I think it is important to build up the experience by doing follow-up angiography. However, the right timing, I think
Okay,
at the
so
moment...
when would you do follow-up angiography in a DCB case now? Control
Just
angiography.
to prove that what we have been doing 6 months before is still working very well. And especially if you are using...
So in an asymptomatic patient, would you do it if it was a high-risk lesion in a high-risk location?
I would suggest to do that.
When would you do it? At 6 months, 9 months? When would
6
you do
months,
it?
6 to 9 months.
6 months.
Yeah, 6 to 9.
Oh, okay.
Not very early.
We know that whatever we do in the coronaries, some patients are going to have restenosis. Is the morphology of a DCB restenosis any different than what we've seen previously with balloons or with stents?
Well, it is probably different as compared to the ISR in drug-eluting stents, because it tends to be softer, it tends to be more diffuse. But the few cases that I've seen...
So you think it's more diffuse when you have restenosis in a DCB than with a stent?
In de novo disease. I mean,
I'm talking about de novo.
De novo,
Yeah. I'm talking about de novo.
I was surprised to hear that, and that's why I wanted to hear Antonio as well, because I would have thought, Antonio always shows me these cases where he's done long segments of DCB,
And you get
when he
focal
gets the
recurrence?
restenosis, it's focal, and he treats very focal.
It's much
is.
more frequent to be focal, absolutely. What I do in all patients, I do DCB. I recommend 1 year follow-up with multi-slice CT.
Well,
Because if you have a good CT program without a stent, you can really evaluate the lumen very well, and that gives you...
the real issue is that
Good
at the moment
information.
we can integrate the imaging modalities, and I have to say that what we are doing is not doing coronary angio anymore. In terms of follow-up, we are using the photon counting CT scan. However, in order to have meaningful results, you should be doing that before and then after. And this is also very good in terms of understanding what is the progression of the plaque. There is a lot of debate around the, let's say, pasteurization of the plaque by basically delivering the drug. Obviously, it's all the job has to be done. But I have to tell you that in terms of restenosis, the few cases that we have seen are mostly related to a technical problem. In other words, what I'm talking about is, if you do the procedure and then you leave some kind of very long dissection, you didn't prepare very well the lesion, you are accepting something more than 30% residual stenosis. In that case, you see a lot of long diffuse disease. But if, like Antonio said before, if you do that very carefully and you have fantastic result at the end, tends to be more focal. But again, I actually, I tell you, build your own experience, because that's the only way to trust DCBs. And this is an important word.
Yeah, Marty, we did so much work in BMS restenosis, in DES restenosis, to understand the mechanisms, to classify it. And I kind of feel that's lacking a little bit.
Yeah.
We've done thousands and thousands of patients with DCB. We always talk about, we show angiographic follow-up, but I feel, honestly, like, we know very little about DCB restenosis.
Yep.
I think it's, for those of you who are doing so many, it will be interesting to, next year at PCR, show some data and try and characterize what does DCB restenosis look like, how often is it focal, how often is it diffuse, get some imaging. I think that would make a great paper and help our understanding of this technology.
We have a prospective study going on. We already enrolled 80 patients with systematic angiographic follow-up with the Magic Touch in complex lesions. So next year we will
But tell us about the failures too, because we're only talking about success.
One thing is absolutely important, and I'll give you just a second. One thing is important. I mean, I've been traveling around in multiple hospitals, and I have to tell you, the one thing that is really lacking is the standardization of usage. So I have seen all the things that Sandeep just said not to do before. I've seen all of them, including the fact that one colleague, for example, I do remember, was trying to cross with the balloon, was not able just to put it on the desk and said to take it again after 5 minutes. So the drug was not there any longer. And we know that. But the very first thing we should be doing is to standardize the use, the pre-dilatation, the time of the inflation, all the things that are still there ongoing. So we just started. That's what I think. And also in terms of delivering evidence concerning the failure, which are there, obviously, we need to understand, first of all, how to use this technology. And then we can think about how to basically do all the things that we should be doing. But please, Alok.
I just want to also mention to Marty's comment, most of the DCBs we're using don't have kinetics that really release drug like drug-eluting stents. They don't really get to the point where DES can elute for about 180 days. Most DCBs don't. So we may have a catch-up phenomenon at the tail end of the 6 months, and 6 months may not be adequate to evaluate DCB. The other thing I want to comment is DES restenosis is different than BMS restenosis. Yeah. We showed that it's more proteoglycans, less muscle cells, a different type of tissue. That may not even be responsive to more DCB. We don't really know.
Yeah, just to reply to the first part of the thing that you said is that with DCB you don't need to have a prolonged release of drug because you don't have metal.
I didn't say that. I just said that we don't have, the kinetics are not as good, no matter what you say, as a drug-eluting stent.
Yeah, that's true.
Okay, one last question.
I just had a question about the safety of leaving non-flow limiting dissections. Is there a role for physiology?
Well,
using PDPA.
Let's say that no flow limiting, well, there are no flow limiting and low flow limiting. You have seen, all of us, we have seen that a small, just a tear doesn't really affect anyhow let's say, the follow-up of that lesion. Of course, if it's flow limiting, different animal. You can use the physiology, of course, but the real problem is honestly the thrombosis, because we are all afraid about leaving a lesion that can be thrombotic, of course. If you leave a lesion that is, let's say, physiologically significant, you need to use another balloon. So, okay, you can use either the physiology or the imaging, but honestly, I do believe we cannot link the use of DCBs to the use of physiology or imaging in all the cases. We need to, as Sandeep pointed out, we need to teach our eyes to understand what you can leave, what you need to fix. And that's the real question now.
And if you want to do that, do wireless, because then if you have some dissection, you go with another wire, you might find, a false lumen.
Yeah.
Catheter-based, for example, using catheter-based FFR, was more about what level of PDPA, if the dissection is there.
Yeah, I've seen Antonio use physiology sometimes in the borderline cases. Don't you, Antonio?
Yeah, we used physiology 3 years ago when we were at the very beginning and we needed also medical legal. We were afraid not to place a stent and leaving a dissection.
Sure.
We are going back 3 or 4 years ago. Now we learned and we rarely use physiology. I still use physiology when I treat LAD long lesion diffuse disease. When I treat LAD long lesion diffuse disease, I like to place 2 wires. One FFR wire that I leave there as a monitor and one working wire to perform the procedure. And I see what's happening during the procedure. I use that only for long lesion of the LAD. That's it.
Yeah, I'm basically doing the same. The real problem, Antonio, is sometimes you are creating spasm with the presence of 2 wires. So it's hard to generalize. And I have to say, going back to the question of the colleague, I mean, at the moment, the ideal way to evaluate should be the non-invasive physiology that you can do with some multiple technology that you have. But again, there's no final single word or sentence here. We really need to, increase the level of knowledge.
Okay, one last question, short answer. If you have DCB restenosis, how do you treat it? You treat it with another DCB or you just put a stent in?
If it's a small vessel and the restenosis is focal, I treat it with another DCB. If it's a vessel over 3 millimeter, I treat with a stent. I think a short restenosis, a stent, nothing wrong. nothing wrong with it. I think it's-
Okay, this was great. Okay, so we have a few more presentations, and now we're going to talk a little bit about clinical trials as well. So Bernardo Cortese is going to talk about Piccoletto 6 study. I will not let him talk about Piccoletto 1 through 5.
For the sake of time, I'm going to skip the first 5. But I'm going to arrive to up to 10, not today. So yeah, I'm speaking about on behalf of these investigators. Wow, the room is packed. I like that. So on the investigators of Piccoletto 6. Yeah. So we said at the beginning, Martin Leon said at the beginning that DCB is a hot topic in interventional cardiology. In a DCB hot topic, the hot topic is it better paclitaxel or sirolimus? Okay. So these are some studies that investigated the differences in terms of angiographic performance of paclitaxel or limus drug-coated balloons. In the de novo limus, you can see here that the differences are the performance are quite different. Specifically in Transform 1 trial, Sequent Please did outperform the Magic Touch in terms of angiographic parameters. Can you close the cellular phone, please? Thanks. So, despite there is no difference in terms of clinical performance in these small size studies. But many doubts actually came out from Transform 1. For example, you can see here in a analysis of each center's performance, there is a huge difference in terms of performance. In some centers, I would say most of the centers, there is a much higher performance of paclitaxel-coated balloons. In some others, Sirolimus-coated balloon is better. So this led us to several hypotheses, but most of all, we would like to understand if there is a real difference with a larger population of patients. And the other important reassuring information for us is that at 1 year follow-up and at a 2 year follow-up recently accepted in neurointervention, Eastbourne study showed that the clinical performance of the Magic Touch technology is working well in terms of safety and efficacy as well. So let's come to the Piccoletto 6. This is an international multi-center investigator-driven real-world study sponsored by my foundation. We have a core lab in Ferrara, and Simone is the PI of this study. We treated and analyzed 270 consecutive unselected patients treated with DCB, several types of DCB for de novo lesions. All of them underwent an elective angiographic follow-up. So we wanted to assess the performance immediately and during angiographic follow-up. The primary endpoint is a little bit weird, new, which is the late functional loss in paclitaxel and sirolimus-coated balloon, where we expect a non-inferiority in terms of this endpoint. And we also have a co-primary endpoint, which is the late lumen loss. Today, I'm presenting the preliminary data and preliminary information with a comparison between paclitaxel and sirolimus. Later, we will go through the final analysis with a comparison between the several devices. So this is a slide which is showing how the MuFR has been validated so far for stent trials and for Piccoletto 2 MuFR, recently presented at CRT this year and in course of publication. But we have some data about this new modality of assessment of physiology. So this is the primary endpoint in the sample size calculation. We decided to have this non-inferiority margin with a non-inferiority margin of 0.06 between paclitaxel-coated balloon and a sirolimus-coated balloon, expecting a loss in a functional function of PCB of minus 0.02, taking into account the results of Piccoletto 2 MuFR study. So after that, we calculated a population of 230 patients. These are the centers that did participate. All of them are expert centers in dealing with de novo DCB angioplasty, coming from Europe mostly. We also have Bharat from Singapore. And this is the final population that we enrolled, 183 patients with a paclitaxel-coated balloon, most of them treated with a Sequent Please, and 87 patients, most of them treated with Magic Touch sirolimus-coated balloon. This is the baseline characteristics. You can see here that the age is a little bit higher for the sirolimus-coated balloon group, and the acute coronary syndromes were a little bit more for the paclitaxel-coated balloon group. For the rest, there is no significant difference. In terms of procedural characteristics, you can see here that the predilatation is quite high, a little bit higher for paclitaxel, but this is 96% is very high, so it's clearly showing the expertise of the centers that participated to Preclinical 6. There is a slight difference in DCB inflation. Intravascular imaging is not very high, 28%, but higher than other studies. Bale stenting, very similar, device success high in both studies. And this is the QCA result. You can see that reference vessel diameter is 2.2 millimeters overall, no significant difference. Percent diameter stenosis after PCI higher for Sirolimus-coated balloon, so the acute performance is worse, probably related to the lesion preparation, which is 37% versus 33%. And the percent diameter stenosis at follow-up is higher, which is better for paclitaxel, with a net gain that is, I'm coming here, net gain which is 0.75 for paclitaxel and 0.69, much better than Transform 1 study with sirolimus. Late lumen loss, which is the co-primary endpoint, is minus 0.02 with paclitaxel, so meaning that there is lumen gain in many patients, and 0.12 for Sirolimus-coated balloon. Again, no significant difference. And positive remodeling, which is there, we know more for paclitaxel, also in this study, did occur in 55% of the cases, whereas there is still also for sirolimus. I remember you that there is positive remodeling also after POBA, but it ranges between 10 to 20%. Okay? If you recheck POBA in native vessel disease, 10 to 20% have remodeling. With sirolimus, we have positive remodeling in 40% of the cases. And this is the cumulative frequency distribution of net gain. So coming to the physiological results, which is the novelty of this study, you can see here that the vessel micro-QFR is 0.87 in a paclitaxel and 0.84 in a Sirolimus-coated balloon, so no significant difference. And the primary endpoint, which is a late functional loss, is 0 for paclitaxel and 0.03 for Sirolimus-coated balloon. So again, no significant difference for the primary endpoint. And this is the slide. So I have to acknowledge some limitations for Preclinical 6. First of all, this is not a randomized controlled trial between two different philosophies. This is only preliminary analysis. So far, we have 77% of the core lab analyzed data. In the future, hopefully in the next 2 months, we will have the performance analysis of all DCBs, and we will have also some more information on the clinical performance. So my conclusions, Preclinical 6 is the first study directly comparing several types of DCB, all with angiographic and physiological derived assessment. This is a real-world complex setting. I would like to underline that 44% of the patients had diffuse lesion. Lesion length on average is more than 20 millimeters, with a state-of-the-art lesion preparation at expert centers. PCB and SCB showed similar late functional loss and late lumen loss, with a non-significant trend towards better performance of paclitaxel-coated balloon. I'm waiting for the final results in a direct comparison between drug-coated balloons. Thank you.
Very interesting data, Bernard. I think we're going to have questions about the late follow-up. But before we get to that, for you and Antonio, do you see any difference in terms of acute performance deliverability between different DCBs?
But I think in general, I would say that Sirolimus and Magic Touch is very deliverable. It's probably the most deliverable. I have a question to Sandeep and Bernardo. Short answer. After the presentation of Aloke, which is, I mean, the data are real, would you, and your data that you just presented, that Sirolimus may have a little bit less advantage in luminology, yeah. Would you still prefer a paclitaxel if you have to use too long 40 millimeter paclitaxel on the LAD, or would you accept maybe a little bit less acute long-term performance of Limus, but not paying the price that most probably you have to pay?
You go first. I go first?
Okay, you go.
You
okay,
go
I'll
first?
go. Okay, I'll go. So the 2 points, I also believe that even though the remodeling is not as good as paclitaxel, functionally, patients are asymptomatic when I see them when they have the check angiogram. The second point is when I use a DCB in a STEMI, or as you said, a long LAD lesion, if I'm using 3 or 4, in an impaired LV function, I tend to use Sirolimus because of the slow flow. And I've seen slow flow in STEMI patients a lot with paclitaxel. So
Yeah.
I tend to use more Sirolimus.
Yeah, I agree with you. I would like to add something. If we have a small vessel, very small vessel, 2 vessels, probably I prefer paclitaxel now because it exerts a larger luminal gain. In the larger vessels, a more proximal vessel, I prefer to use Sirolimus so far. But if I have a very long lesion, as you said, 240 or 80 millimeters in the LAD, I would not like to use 2 paclitaxel-coated balloon for the same reason that we have seen with a lot.
Yeah.
I wanted to add one more thing. Is the late loss fair? I mean, really what matters is the patient's clinical symptoms, and I wonder if sirolimus is ever going to equal paclitaxel-coated balloons, because the effect of sirolimus is not to kill medial muscle cells. Every time we do the experiments, we see that the media is lost. Half the media is just gone because it's killing the medial muscle cells, so the vessel dilates. We saw the same thing with paclitaxel-coated stents back in the day. So, is that a fair comparison, late loss, when we know that one is cytotoxic and going to kill vessels, cells, going to have dilatation, you're going to have probably better late loss. Lumen's going to, you had negative late loss in this experiment. So I'm just wondering if the comparison is fair.
Yeah, we decided for this reason to use another primary endpoint. So what is important is that we have a negative FFR so far, and in this study there is no difference.
Yeah, but you use the micro-C, you use the
Yeah.
micro-QFR. Is that really validated? I wasn't sure if that's really validated.
For DES, yes, not for DCB so far, but also the QFR is not validated.
Sorry.
Yeah, go ahead, Samir.
I just wanted to ask 2 questions. One, there is a recent paper in the current issue of Euro Intervention which showed that more medial dissection led to, with good flow, led to better luminal gain, better late luminal enlargement. Did you see that in your study? And second, to Alok, what matters, in your opinion, most, the dose of the drug inside the vascular tissue or the duration it stays?
You want to?
Yeah, so we don't have intravascular imaging, only 20% of the cases, and we don't have the core lab for that. So I cannot tell you which is the effect of each drug in the media. So I cannot tell you that. There is no data.
You ask a good question. When we do pharmacokinetic studies, as long as the dose is above the therapeutic biologic threshold for the drug, we say that's having efficacy. Now, if it's 10, it really matters more for paclitaxel. You really do not want 10-fold higher dose. In some situations, you really want to keep it at the therapeutic threshold and then have it tail off slowly. For sirolimus, it's less important. It can go higher than the therapeutic threshold and not going to have any untoward effects. If paclitaxel gets too high, it really can cause some very serious arterial wall changes that I think are dangerous. So I think it's really different for each different drug, but the duration matters a lot as well.
For sirolimus?
For both, you got to have drug, got to be there, like Marty's question was asking, it's got to be there sustained for at least 60 days, I would tell you, to have a really good therapeutic effect.
So in light of that fact, the next question to Sandeep, if the dose matters, then would doing a cutting balloon every time and then doing the DCB, would it deliver a better dose to the vascular tissue?
Theoretically, yes, but it's not been proven in terms of, even when they did in ISR, they only could see the angiographic improvement, but not clinically. So I don't know whether that makes any difference. It's too early days to do that. Yeah. But one thing I would like to say that with in my last 10 years of my experience with DCB, I've seen 3 aneurysms, and all 3 have been in paclitaxel. Yeah. Now, I don't know why and how, but
that was my question. We keep talking about positive remodeling, but sometimes this can be pathological dilatation, right?
I don't like
hit some negative.
Yeah, I don't like the idea of dissecting the vessel purposely and trying to deliver Now, sirolimus, I think it's not going to have a big effect, but paclitaxel especially, it may prolong the drug, but it's may have some untoward effects.
That's a very interesting topic, Mari, because I see some startups developing, micro-tear balloons. Right, scoring balloons, but not as perhaps aggressive as cutting balloon. Together, with sirolimus. So I think that might be an interesting concept.
You know, we're going to move on, and Marco is not here yet, so we're going to... Oh, he is! This is perfect, yes. So Marco has got a good case, and then we're going to conclude with our final presenter in just a moment.
Thank you very much, Martin, Alex. Good evening, everybody. Sorry, I was engaged in another session. It's a shame that I'm late, but I was enjoying the last 10-15 minutes discussion. My task and my privilege today is to share with you a case. It's a complex three-vessel disease patient that we did treat during a live case early March this year. Relatively elderly female lady, 86-year-old with classical risk factors. I'm not going to spend time on. Perhaps the most notable one to be discussed is that she had a true intolerance, not allergy, but true intolerance to aspirin with angioedema and a respiratory crisis in the past, to the point that she did not even want to hear about trying aspirin once more. She was on clopidogrel treatment. She was admitted with a non-STEMI and relatively low ejection fraction. This was the treatment, and this was the angio. The ostial RCA with some degree of calcification. This very frequently is the case. And the left system was, as shown here, relatively okay circumflex with mid lesion. And then a very long lesion, which is perhaps more visible here, from ostial LAD all the way to distal LAD. It's extremely diffuse disease. Now, of course, this case is a three-vessel disease case that has been, as per routine care in our center, discussed in the heart team. I don't know whether we want to stop here a few seconds or I should go ahead. I look to the chairs to have some guidance. Okay, so the decision was pretty straightforward. The surgeons didn't want to operate on the lady. We assessed whether impella support was an option. So we did scan the femoral arteries, and that did not turn to be the case. It was small vessels and diseased vessel. So then we decided no way for impella. And then we tried, of course, to plan it as we frequently do, to be honest, as a stent-sparing approach, meaning let's try to stick in as limited amount of stents as possible. And at the end of the day will be the patient, how the patient will react to your lesion preparation, which is setting the rule. It's not that you come up with something magic up front, you try. We didn't try for the RCA, and actually RCA was treated offline because we said it's ostium RCA, it's a lot of calcium, we will never be able to treat it without stenting. So we did a very classical approach, pre-dilatation. We implanted the stent in a moment in which we thought would have been reasonable to do so, but MLD, as you see here, MLA, sorry, was relatively small, in the 7 area. So then we use a OPN balloon, very high atmosphere, we got something better. And then we started off with the left system. This was broadcasted live. We decided to modify the long lesion in the LAD with the rotablation. 1.5 burr, single passage until the burr did pass, of course. And at that moment, the burr was removed, and you simply start pre-dilating the lesion and try to be as gentle as possible, and you keep on going until, of course, you have reached something which is decent. So we started with a 2-0 distally, 2-5, up to 3-0 in the distal LAD, up to 4-0 in the proximal LAD, and this was more or less the angiographic appearance. At that moment, we gave Magic Touch a try, and so we Magic Touch distal LAD. This was the IVUS. The IVUS, the calcium was there, but it was decently cracked. So we said, let's try to go for Magic Touch, and we did use 2 long sirolimus-eluting balloon. You see, 2.5 distally and 3.5 proximally, and this was the outcome. So we were relatively happy about mid and distal LAD, not so much about proximal LAD. We said that the lesion was not enough prepared. So that pushed us to be slightly more aggressive, use a 4-5 scoring balloon, which ended up opening up the lesion in the ostial LAD, but also having quite an important dissection. The patient started having some EKG changes, slightly symptomatic. Perhaps because we were broadcasting live, I cannot tell you honestly, but we decided without hesitation to put a stent in the proximal LAD left main, crossover approach, classical approach. I'm not going to spend time on pot, rewiring, repot. And at the end of the day, that was results. So we ended up having a single last implantation, a single stent implantation left main LAD crossover, perhaps a long one, I do not know. But mid and distal LAD was very well treated with DEP. The patient was completely asymptomatic at the end of the procedure. I don't have any angio follow-up because that was not scheduled, but the patient remains completely symptom-free on monotherapy with clopidogrel since day 0. This is the IVOS findings after the procedure, and this is my take-home message, which we can skip for the sake of time. Thank you very much.
I think your message is very clear, and I totally, if you have any doubt, you should stent at this time, because stenting a lesion is not a crime.
I thought it wasn't.
Especially left main ostial LAD, probably. Yes.
No, I think it's an important message. Just go ahead, because we keep saying this is the award between DCB and DES. It's not. It's a strategy.
But you stented focally, relatively focally, with a 4 millimeter stent. Even if you didn't have a drug-eluting stent, most probably a 4 millimeter metallic stent would not reach the nose. And you treated distally with a drug-coated balloon. So I think you did what I would like to be done on myself if I come to Lugano.
Can I record this one, Antonio? I record this one and I take it with me at home. Thank you.
Yes.
So I was a great enthusiast of left main bifurcation PCI with double stent strategy, but due to notorious of LCX ostium, now I am a great believer of DEV, and I am routinely using drug-eluting balloon at left main LCX ostium and giving left main to LAD crossover stenting. So I have 3-4 questions. That's why I have taken chair beside the mic, so I could have asked so many questions, but due to time, my first question is, should I continue this? The second question is whether any difference between a scoring balloon and cutting balloon in comparison to creating dissection in the vessel. And third is, how do you manage overlapping of a long diffuse lesion while you are giving 2 overlapping drug-eluting balloons? So how you manage to overlap that? Which trick you use to manage so that the no area remains bare? Thank you.
Mark, we need short answers because 10 minutes to finish.
Yeah, so I can try to address all these 3 points. The last one is easier. It depends on the length of the balloon that I have available on shelf. I try to deb from healthy to healthy. So if that is the case with the reasonable balloon length that I have on shelf, I try to have a very big overlap. If that would prevent me to go from healthy to healthy or open up a third balloon, perhaps in this case I would not do it. But normally the overlap is generous, not a few millimeters as the one you would do with stent. I think that is what I'm doing. Circumflex, ostium circumflex, I think you're doing very right. Sometimes angiographically you ask yourself whether you need even to open the strands toward the circumflex, but the bifurcation club, at least in Europe, says that you should do it, for at least for the ostium. And I think going there with the DEB, it's very reasonable. I like the idea. The second point, I probably don't remember anymore.
Do you think any difference between the scoring balloon and cutting balloon in creating dissection?
I think there is a difference in price, first of all, and in the amount of damage that you would do. That's why I try to upscale. Scoring balloon first and then cutting balloon. Cutting is extremely aggressive, and I have not so many cases where I were forced to use cutting and then I couldn't stay away from stenting. So scoring balloon to me is more an intermediate step.
We need to respect time.
We really have to finish the symposium or else they throw us out. Okay, so our final speaker is Azim Latib. Azim, of course, used to be a European. Now we claim him as an American. You like a game called football with a round ball. We like a game called baseball with a round ball. And Nazim is our cleanup hitter, which means he hits a lot of home runs.
There you go.
So he's going to
No pressure.
So he's going to finish and talk about some really interesting upcoming clinical trials with Magic Touch.
Thanks so much, Marty. I'm going to try not to keep you all from your dinner. I know it's late in the evening. So I keep saying this every time I give a talk here in Europe. Drug-coated balloons are the things I miss the most in the United States when it comes to what I do every day, which is be an interventional cardiologist. It's the one device that I wish I had and I miss. So when I see Sandeep showing 100 slides with 50 cases, and I'm very jealous that you guys can do this every day. But soon we'll have that, and thanks to Concept Medical for allowing us to be able to get some trials where we'll be able to bring the balloon to the United States and have it commercially. There have been a lot of patients treated. We've now received approval from the FDA to start 2 trials in the United States that will help us get an indication. One's for ISR and one's for small vessels. I'll take you through each a little bit. I'll be leading the study with Ajay, who can't be at this session, but he's a great partner and someone I really enjoy working with. And we already started enrolling in the in-stent restenosis study in the United States. So this is going to be a prospective randomized 2-arm study. Single-blinded, so we're trying to blind the patients. That is the core lab. The physicians treating the patient will know what device the patient got. We're randomizing 492 patients in a 2-to-1 randomization of Magic Touch versus POBA. You might think crazy. Why are we doing POBA for ISR? Well, in the United States, there's really nothing approved for restenosis. And most physicians are still pretty uncomfortable about putting a stent inside a stent and to treat restenosis like that. So we thought we would, one study has already done that, so Agent already did this. And it's probably one of the coronary studies that enrolled the fastest we've ever seen. So we're hoping to do the same. Our primary endpoint at 12 months is target lesion failure. And we're really going to be enrolling patients both with stable angina as well as acute coronary syndromes and silent ischemia. We're using what we've learned from Europe to ensure success in the study, and so patients will only be randomized after successful lesion preparation, defined as you heard it here today. Residual stenosis less than 30% without flow-limiting dissections, and looking at TLF at 12 months. I'm going to go forward. We'll also look at all the typical secondary endpoints that you would expect of a clinical study. And so this will be one of the largest, well-conducted studies with Magic Touch, where everything's going to be core lab adjudicated. We have independent events committee, and I think we'll get a lot of really good data from this that will be impactful worldwide. We also have a small vessel study that is approved. We haven't started enrollment yet. This is global. We have Antonio helping us with this study with all his experience. And as you can see, this is a much larger study. It's 1,600 patients being randomized 2-to-1. Drug-coated balloon versus either everolimus or sirolimus eluting stents, because those are what are available in the US. And this is a small vessel study, which means vessels of 2.75 millimeters or less. And again, we're going to be looking at target lesion failure in patients with stable angina and as well as acute coronary syndromes. We're just really excluding STEMI patients from acute treatment in this study. It's a non-inferiority study, and like I said, target lesion failure. And once again, I think it's important in a study like this, we're going to randomize after successful lesion preparation in the cath lab to ensure that we really can take away some of the bias that comes from inadequate lesion preparation in a study like this. I think you've heard from everybody today how important lesion preparation is to outcomes, whether you're treating restenosis or you're treating de novo disease. The endpoints at 12 months, patients will be looked at 30 days, 6 months, and 12 months. And again, we'll look at all the typical secondary endpoints you would expect. Neither of these studies are angiographic studies. These are powered for clinical endpoints. And I think these data will be really important for us to understand how these devices will impact our daily practice. And I certainly hope that both of these studies will allow me to have this balloon commercially available in my cath lab. So this is what we have to look forward to the US. Two very important randomized studies, one in in-stent restenosis that has started enrollment, and soon will start enrolling in our small vessel study too. Thank you so much.
Any questions for Azim? Okay, then what I'll do is let me quickly conclude, and then you have some really good speakers here. If you have any pressing questions, you can grab them before they leave. So we've had really a very comprehensive 90-minute symposium, starting with understanding more about the experimental physiology and pathology. We've learned, I think, that there are safety issues with drug-coated balloons that at least we should be aware of. Knowing how clinically relevant they are is still being discussed, and it differs. Whether you have a paclitaxel or a sirolimus drug-coated balloon. Similarly, there may be some differences, at least in animal studies, of efficacy from the standpoint of pharmacokinetic profiles of the various drug-coated balloons. How that translates into important clinical differences in patients is not entirely known. There is a recipe for how to do a drug-coated balloon case, and I think you should listen to some of the things and some of the tips and tricks from Sandeep and Bernardo and Antonio to really understand how to best use these devices. So we do have to standardize the procedure. I won't try to go through all of the tips and tricks, but it's very important that you do it in a very careful way and treat this very seriously with vessel preparation and making good decisions about which patients may have a result which is inadequate with DCB alone or with preparation and needs to be converted to drug-eluting stents. There are some very complex lesions that can be treated with a DCB, and we've seen some excellent case examples. There are some other clinical trials that are ongoing with angiographic follow-up that will give us more understanding of these complex lesions and their response to DCB. And you've also heard that there is some rationale for what's a more integrated or hybrid approach of DES and DCB in some of these most complex cases. So you've really seen, I think, a great spectrum of DCB use. I will say that there are more clinical trials that are being done. You've heard 2 of them that are in the United States. We don't have as much experience as you do, but I think we will learn quickly over the next few years. And I think DCB finally will be integrated into our armamentarium of how to manage patients with complex coronary disease. I would argue that less so for DCB than DES, that the different devices don't really represent a genre. By that I mean, so many of the DESs are similar in terms of their effects. I'm not so sure with the drug-coated balloons that they're all the same, and I think we need to learn more about that. I think there may be more differences than similarities, and you may joke about the FDA, but they do have some rationale for allowing certain devices that don't have enough good clinical and preclinical data because of safety considerations. And my final point is that in the next 5 years, it'll be very interesting because as we accumulate more data, we'll start doing some very interesting clinical trials. And it may be that we take a full circle with PCI and the drug-coated balloon becomes the primary treatment, or what we would call the default treatment in the majority of cases with bailout DES, rather than the way we currently do it, where DES is the default therapy essentially for all lesions. And that will be a very interesting transformation to observe. So with that, I think we'll close the session. Have a wonderful dinner. Enjoy PCR, and we hope to see you at other meetings, including TCT, in the future.